Well, hi, everybody. We're going to go ahead and get started. I want to welcome everybody to this fourth meeting of CSG's National Long-Term Care Workforce Network. I'm Sean Sloan. I'm a senior policy analyst at the Council of State Governments here at the national headquarters in Lexington, Kentucky. Here is our agenda for this afternoon. After a quick introduction and project recap from me, I'm going to turn things over to a group of folks from an organization called AMDA, the Society for Post-Acute and Long-Term Care Medicine. This is the medical specialty society representing over 50,000 medical directors, physicians, nurse practitioners, physician assistants, and other practitioners working in various post-acute and long-term care settings around the country. They're going to talk about efforts to define the nursing home clinician workforce shortage. You will be introduced to all of these folks as we move through our time this afternoon. They want this to very much be an interactive conversation with you. So your questions and comments will be welcome throughout the presentation, and they will have questions for you as well. We encourage you to make liberal use of the Q&A and chat functions here in Zoom to submit questions and comments. Please stick around until the end, and I'll tell you what I know so far about our next network meeting, and we will wrap things up for today. I know we have quite a few newcomers joining us today, in addition to lots of folks who have become regulars. I'm going to give a special shout out to Raina Reddish, who is a Director of Government Affairs for the Tennessee Healthcare Association, which represents 2/3 of the long-term care facilities in that state. She recently got in touch about wanting to join our network mailing list, and also reached out to several of her counterparts in Maine, Indiana, and North Carolina. So we welcome folks from all those associations that represent long-term care facilities and everyone else joining us today as well. That's how we hope to, this expanded network will work, with folks getting in touch to add their names to our mailing list, and also passing along the registration link for our meetings to other colleagues who may be interested in attending. So just a quick reminder of what our current project is all about. Last year, with the support of the Commonwealth Fund, CSG put together an 8-state interbranch task force of state policymakers that convened multiple times over the course of the year and advised us as we put together the CSG Long-Term Care Policy Guide, which you will find on our website. One of the 3 focus areas we had for the project last year was revitalizing the direct care workforce and supporting family caregivers. And in the policy guide, you'll find a number of strategies states have deployed to address those issues in recent years. That focus area is now the jumping off point for this new project for 2023. We are pleased to again be working with the Commonwealth Fund to build on the work we did last year. This project includes using the model for last year's 8-state task force to build out this national long-term care workforce network. We're developing a new website, a national online resource center that we hope will become a clearinghouse for all the relevant work being done on long-term care workforce policy around the country. We hope our network members will share relevant legislation, policy reports, and other materials that we can post to the website. And as I said, please feel free to make extensive use of the chat and Q&A functions here on Zoom to share any links with us and with the group today, to tell us about who you are, to connect with other attendees working on these same issues, and of course, to submit questions for our presenters. We also, with this project, have the opportunity to provide technical assistance services for up to 5 states. If you believe policymakers in your state could benefit from a detailed briefing on how they might take action to address long-term care workforce needs, please get in touch. So, without further ado, I want to welcome these folks from AMDA to the conversation. Just a quick history of our contacts and association with AMDA. As part of the task force project last year, our 8 states were invited to curate a state-specific conversation on long-term care. Following our meeting with Virginia that was moderated by Delegate Chris Head, we heard from Dr. Christian Bergman, who is a geriatrician and assistant professor at Virginia Commonwealth University. He in turn put us in touch with Dr. Dan Heimowitz from Pennsylvania, which was another of our task force states. as we worked toward finalizing our long-term care policy guide. They were able to review a draft manuscript and provide some great feedback. Most notably, they noted that we failed to mention the important role of the medical director in the long-term care setting and policy decisions that have been made to enhance that role. And while we focus a great deal on shortages in the direct care workforce in the policy guide, they noted that there is also a shortage of physicians, nurse practitioners, physician's assistants, and yes, appropriately trained nursing home medical directors. So we're going to hear much more about that today. In the interest of time, we will have these folks introduce themselves and detail as much of their professional backgrounds as they see fit as we move along. To get us started, I wanted to first turn things over to the aforementioned Dan. He is a board-certified internist and geriatrician and has been in private practice in Levittown outside Pennsylvania since 1986. He's a past board member and secretary of AMDA and is currently a member of the AMDA State-Based Policy and Advocacy Subcommittee. Dan, thank you and your colleagues for joining us today. Please take it away.
You're welcome. Thank you for allowing us to come. By the way, I'm outside of Philadelphia, to be super clear if I wasn't. Ooh, the video now works. Hey, so for some that's good, some that isn't. So here I am. So thank you very much. We hope to have a good interactive hour with everybody. So we're going to be talking about defining the nursing home clinician workforce shortage, but we thought it'd be a good idea to tell you a little bit about AMDA before we continue. So next slide, please. And I will be your facilitator today. The first part, we're going to talk about AMDA and the role of healthcare practitioners in post-acute and long-term care. Next, please. So AMDA, which initially was just for medical directors, has really expanded to be more inclusive. So not only do our membership does not only include medical directors, but it's the attending physicians, nurse practitioners, physician assistants, other people with doctors, anybody who's involved and engaged in long-term care is welcome at AMDA. We'll talk a little bit about our certified medical director certification. There's also an AMDA Foundation. We have our peer review journal, which is JAMDA, which is all online now. We do have 2 seats in the AMA House of Delegates, which is a good thing because we bring resolutions to the AMA, but also when it works out, we can take these resolutions and stay with the medical society, actually bring them on a state level. And we're also happy to say we've been a sole source grant award from the CDC to promote vaccination, which is something we're very excited about. Next slide, please. So this is the Earth. That's where we live. Next slide. Well, next. There we go. So here's AMDA's vision on this said Earth, which is a world where everyone receives the highest quality care, which is terrific. Next slide, please. So this is just a little bit, if we're talking about what is post-acute long-term care. So this is the spectrum of it. Next click. So it's obviously not just the nursing home, which is both short-term and long-term, but more and more we've been inclusive of assisted living, which we're not going to talk about specifically today, but the assisted living population is looking more and more like the nursing home patients these days. Next click. The TOC there stands for transitions of care. And, you know, the way that the healthcare system works, you know, is the hospital now is more or less a way station. And many of the costs in long-term, in medicine wind up going into long-term care. Next click. Which just goes to show that, you know, this is separate, obviously, from the community. I'd even say that a lot of places that have continual care, CCRCs, community care, residential communities, even some degree of independent living is being involved in the spectrum. So there's of long-term care. There's a lot of places where AMDA members go to for long-term care. Next slide, please. So why is this important? Obviously, as everybody should know, there's lots and lots of older people. We're in the midst of it doubling and will triple by 2050. It's very expensive. Many people will need long-term services and supports. That's the LTSS. And we're talking about, like in the year 2020, we're talking about something like $400 billion with a B, $400 billion were spent on long-term services and support. I mean, this is a big part of where monies are spent out. People can't afford it. Obviously, the sicker they are, the more needs. the more likely they are to use Medicaid funding, which is largely is on people in long-term care in the nursing home. Next slide, please. So why should this be important to our audience today? Well, long-term care is a significant part of state budgets, which we think obviously at AMDA should be go to the people who are providing the care. There's a shortage of labor across all settings, but including long-term care. Poor quality to us means spending more money. It's inefficient. So how could we work together to improve care, improve efficiencies, and therefore save money? Which is not that saving money is the be all and end all. We prefer the increasing the quality of care, but they're related. Next slide, please. So what's important in post-acute long-term care? Obviously, quality of life, which can be defined in numerous ways, the cost, and the nursing home industry, which is very heavily involved with regulation. So you have to have regulatory compliance also. And the medical director, we believe, is an important part of this. Next slide, please. So how do we accomplish these goals? There's obviously the team that's involved here. There's the physicians, who the medical director is part of the medical team, along with the attending physicians and the nurse practitioners and the physician assistants. The nursing team and administration, we're today, for the most part, going to be focusing on the medical director and physician, nurse practitioner, PA role. Next, please. So the nursing home medical director. By federal regulation, nursing homes must have a medical director who is responsible for resident care policies and coordination of care, not specifically, but overall. Typically, a medical director is an independent contractor. Most facilities, the medical director does 5 to 20 hours a month for administration, quality improvement, and infection control work. Ideally, they're a subject matter expert in this. And hopefully illustrated by our talk today, we feel that the medical director is becoming increasingly active in advocacy for our particularly frail population. Next slide, please. So the ideal role of a medical director, ideally, we would like the medical director to be engaged, to be knowledgeable about the position, helps the facility achieve regulatory compliance, be an expert with policies and procedures, and be a good communicator that can give up-to-date knowledge to all members of the medical team and nursing administration. Next slide, please. So qualifications, we believe a medical director ideally would be a certified medical director, a CMD. Now, this is through AMDA's, the American Board of Post-Acute and Long-Term Care Medicine, the ABBLM, which I don't expect you to be able to rattle off that acronym. This is not by taking a test. This is through education. It's an experiential credential and management. We personally would love to see, and something we struggle with, about showing the value of a CMD. If a nursing home has a medical director who has their CMD credentials, do they provide quality care? There's been one article about this from, I believe, 2009, which the APBLM board is actively working upon. We believe there can't help but be value in this. Next slide. So obviously, it's the whole team. The medical director is sometimes an administrative medical director, but also frequently an attending physician, works with the healthcare providers, looks if medical care is given appropriately, and provides oversight. Next slide, please. Not only is AMDA interested in the education of and the ideal role of the medical director, we're also involved in trying to see if attendings can also have some sort of acknowledgement of giving expert care in the long-term care setting. This is an interesting article if you'd like to look it up. It's mostly covered by a subspecialty designation, but it's something we're actively looking into, basically saying the practitioners who go into nursing home, how can we make sure that they're expert in what they do? Next slide, please. So here we go. That's the very brief background of AMDA and its state affiliates. By the way, not every state has an AMDA, has a state affiliate. Some have states, some are regional. So at this point, if you have questions, I would be curious in the chat to know if you're familiar with your state's AMDA affiliate, if you've had a good or bad experience. I guess what they say stays here, right, Sean? It doesn't go out if they've had a bad experience, right? So do you have any questions about this point, or have you seen something where a engaged medical director, engaged clinicians have made a difference, or are there things that you would like to see? If anybody has a good experience, please raise your hand, or please even put in the chat, were you aware of AMDA and the state affiliates before the call today? So why don't we start that out in the chat, if you could. Were you or were you not familiar with AMDA prior to this call today? And how are we doing in the chat? Okay, so not at all, which is, we hope we've intrigued you, Barbara. Anybody else? By the way, when I said put it in the chat, I meant everybody. Was I clear on that, Sean? I hope to. Come on, feel free. Type away. Yes, familiar with AMDA? No.
Dan, we've got a question in the Q&A section from Shirley Gerard, our friend at CSG East. And she asks, can you talk about the role in providing health promotion, wellness, et cetera, optimizing health for older adults in every setting and regardless of medical and other health problems?
Would any of the panelists be interested in helping to answer that? I mean, I'll take a stab for starters. You know, or Vicky, did you want to say? Did you want to comment?
I was going to volunteer to speak to that. If you would like me to take a stab at that.
Sure, and then I'll comment.
Yeah, it's a great question, and I think that one of the primary things that we focus on in long-term care is really helping every person to have the best quality of life that they can have given the limitations of the disease states that they might be living with. But I absolutely think just well-being is overall from all different aspects is part of what is really important to be focusing on with the policies and the way that care is provided in nursing homes. So I do think that we're important advocates for that. We're certainly not the only ones. Obviously, there's a large team of people that are important to be promoting that, but medical directors are an important part of that as well. I would say not probably all settings. I mean, I don't think probably we see the medical directors necessarily promoting this for people that are aging in their own homes in the community. They might be, because some medical directors also have outpatient practices and may very well be providing that care as well. But I think with their medical director hat on, I think they're focusing probably on people that are living more in a residential setting, like an assisted living or nursing home.
Well, right. And I agree with that. I mean, I think typically medical directors tend to, or many take care of patients in a variety of settings. So you can be a medical director not just in a nursing home where it's regulated. I mean, it's mandated by regulation. There are some medical directors in assisted living, which is something else we can talk about, but there are medical directors at home care companies. There are medical directors in hospice companies. It's kind of a difficult challenge, because the younger and healthier you are, I think the greater the benefits are up for preventive medicine, So I do think as an overall vision, which we could go back to that slide, I don't think we need to, Sean, is, AMDA wants ideal care, wants the best possible quality of care. I think that goes along with all settings, but you need to adjust for the unique settings that someone is in. Christian, did you want to comment at all on that?
I put a brief comment in the Q&A. You should be able to read that. I just remember that the primary attending team, in terms of long-term care patients within nursing home or assisted living facilities, it's a similar role to your primary care doctor. So, preventative screening when appropriate, appropriate medications. I just think as the age of the population increases, we tend to focus more on quality of life and optimizing social interactions and guiding family members. So great question. Thank you so much.
Terrific question. Thank you.
So with sake of time, Dan, I will take over my.
I was going to just segue to you, Nancy.
All right. And I was going
to
add a couple of comments to that discussion. And I think that, to some extent, when you start looking at that skilled and long-term care and of the spectrum of care, it tends to be older adults, people in later stages of life, where sometimes a lot of the preventative health and early intervention and the window for that has gone. But I think that, part of the expertise of being an expert provider in this area, both a medical director who's guiding the care across the entire facility, or just an attending physician who's taking care of their individual panel, is really knowing what is appropriate. And so sometimes it's about what preventative and engaging or life enrichment things can be done to have not just quality care, but quality of life. But we also spend a lot of time focused on what we can stop doing. And sometimes a lot of that quality of life is because we can determine what are treatments that are no longer advantageous at this stage of either of a disease, illness, or a stage of life. And so it's both making sure we're doing all that we can do, but also making sure that we're not doing what's no longer effective.
Right. And Sean, why don't we go to the next slide?
Yeah, I'm Dr. Nancy Istanes, and I am the workforce. AMDA has the Workforce Development Committee, and I chair that committee. And I also am the Chief Medical Officer for Sabre Healthcare Group. So I work for a company that owns and operates nursing homes. And I'm kind of going to start to introduce you to the idea of the nursing workforce shortages, but also the provider workforce shortages. So when we start looking at nursing homes and skilled nursing care within the nursing home, we always refer to interdisciplinary care. And that means that every person interacting with residents and providing that care are really important members of the team. So often, AMDA focuses a lot on what we call the providers. That's going to be your medical directors, your attending physicians, and physicians in general that are writing orders and delivering care for residents. We will also talk a lot about nurses, as well as nursing assistants. But there's also therapists, housekeeping, dietary support, cooks, and chefs in the buildings. All of it is vital and important together. If we can't feed somebody, we can't have a healthy individual. And so every person working to some capacity within the nursing home is really important. Typically, most of your nursing staff, housekeeping, therapy, dietary are employed by the nursing home. Your medical director is contracted and paid by the nursing home on a part-time basis for their service as a medical director. And then attending physicians and nurse practitioners or physician's assistants typically come in and they're credentialed but not employed by the building. They deliver medical care and bill a resident's medical insurance for the care that they're provided. Next slide, please. As we know, we've all heard through the pandemic that there has been quite a loss of workforce across healthcare. And we've heard a lot about the nursing shortage. And this slide just starts to show you the impact of that nursing shortage. And we're going to spend a little time talking about that. But I think we've all heard about hospitals and hospitals who have lost nurses, lost nursing staff, or struggling to hire new nurses. But as you can see here, it really was the nursing home industry that was the hardest hit when it came to our staff shortages. We lost more than 7 times even what a hospital lost. And this has a large ripple effect. There have been a lot of major news articles, especially around the state of Minnesota, where they're not able to accept admissions. They're not able to keep nursing homes open. But lots of states and lots of facilities are actually limiting those admissions. And as you saw in some of the earlier slides that kind of looked at how patients get into the nursing home, we are part of the continuum of care of the whole healthcare system. So if a skilled nursing facility, say, can no longer accept new admissions, that's going to back up your hospital systems. It's going to back up your emergency room. It's going to prevent access to acute level care for many individuals and really affect the health of your overall community from that. Next slide, please. This next slide just shows a map of the United States. This was information from 2021, reflecting back to 2020. So it's a little bit outdated, but we think that it's really still pretty relevant. As you can see, most states are experiencing anywhere from a 20 to 30 to even higher % of their nursing homes are experiencing staffing shortages. And again, so this is looking at your facilities in your states that can't supply enough direct employed staff, or maybe needing to use agency, or maybe needing to shortcut care, or able to kind of slow or halt admissions, which is backing up the remainder of the healthcare system. Next slide. So at AMDA, we are an organization of healthcare professionals servicing the post-acute and long-term care world. However, we really do make some large statements around the nursing home-based staff and the nursing staff, talking about ways in which hopefully those organizations can help to improve their access to staff and quality staff, including things like career ladders, federally funded GWEPs, which are geriatric workforce enhancement grant programs, things that are helping to educate not only our providers, but also nursing staff and other ancillary services in the facilities in geriatric care. We've seen a lot of public pressure to increase nursing staff in facilities and nursing staff ratios. However, a lot of these mandates are really hard to achieve when we don't have people to hire. And there's a dual pressure here. It's both in trying to get more direct kind of hands-on care for the residents in the facilities, but there's also a push to have, full-time infection control specialists, 24-hour RN coverage, certain things that may be also administrative nursing roles within the nursing home that don't necessarily impact the touch time for each individual resident. Next slide. Again, some of the things that AMDA is working on and has promoted, and I'm going to really focus on the last couple because I think that they really start to address both us focusing both on the nursing end, but also on the provider end, is really that we need quality, competent and engaged staff leadership and supervision. So that's from the nursing level, but also from our medical directors. We need to make sure that facilities, while they're not just hiring any medical director to put a name on a form, but they really have somebody who is engaged, who knows what a medical director should do, attending physicians who know how to practice in post-acute and long-term care, that everyone in these settings have adequate skills and training and development, and that is accessible to them. Next slide. Many of you are probably aware of the National Academies of Sciences report. This basically, and AMDA does have a large seat at the table in helping with this, but really helping to look at what the needs are of nursing homes and what do we need as a country related to our nursing homes. There is a lot of push toward minimum staffing standards, but again, it's also in how do we recognize it's not just always the number, but it is also the quality and are they trained and where do we find them? Minimum education and competencies going along that route. We're going to start to transition here into talking about some transparency around the medical director role. And this is something that AMDA is very passionate about. It really came to light through the pandemic when we realized there is no either state or national directory of who is the medical director for each of these facilities. As local health departments needed to reach out to nursing homes, they had a hard time identifying who is the medical provider who is really responsible for the care in this facility. And so we're very adamant that there needs to be both a directory so that we always know who is the medical director of record for each individual nursing home in the country. But also there needs to probably be some training and education around that, some certification to some degree for providing in there. improving financial mechanisms. Right now, it's, kind of the more volume, the more people you see, the more you make, versus truly having a value-based system for the payment of nursing home care, where we're really incentivizing the delivery of quality care and quality outcomes for our residents. Next slide. So talking a little bit about, again, this AMDA Workforce Development Committee. It was established in March of 2022. I chair that committee, and that committee has several facets and components, and we're just kind of getting our feet on the ground as far as really starting to launch. How do we kind of develop a sustainable workforce for the post-acute and long-term care area? We have said that we're going to focus mostly on the providers. While we absolutely believe that all of the interdisciplinary team members are really vital, there are a lot of other organizations that are focusing around that nursing care. And so we'll make statements and comments and have some white papers, but we really want to focus on the medical directors, the physicians, the nurse practitioners, the clinicians who are providing care in the nursing homes. Part of the workforce development program is our Futures program. This has been in existence for well over 10 years. We've had thousands of participants. And this is really an education and training program for early career professionals in post-acute and long-term care. It gives them an exposure to what nursing home care is like, how to be a practitioner in the nursing home, and a small introduction to kind of an early visualization of what medical directorship will look like. AMDA has just published a PALTC provider curriculum. And this is really to help train providers who maybe are coming into post-acute and long-term care, either early in their career or later in their career. And really we're seeing a lot of kind of late career entry. So maybe somebody who's worked in emergency rooms, they've worked in doctor's offices, and now they want to practice in post-acute and long-term care. And we welcome them. But this environment really has a very unique patient population and some unique sets of regulations around the industry that we want to make sure that they're aware of and that they're able to practice in a way that delivers that quality care and quality of life to our residents. We at AMDA are also, through the Workforce Development Committee and through much of our other political advocacy work, really working to get a clearer measure of around what does the provider workforce shortage look like. Some of our later discussion is going to be around what limits our ability to identify that. But I know through the chat that many of you have been asking kind of what is the background of the providers in our facility. And it can be very varied. The majority are physicians, MDs, DOs, and nurse practitioners. Most of them have a background in internal medicine or family medicine. Some have a geriatric medicine background, but there is by far not enough geriatricians to go around to provide all of this care. But most of the mechanisms that we have to tag providers and to be able to see where they're providing care really is based on kind of their basic subspecialty, so internal medicine or family practice, and we don't have a way to tease out. We know from talking to nursing homes that a lot of nursing homes have a hard time finding providers who will engage and come into their buildings. This lack of providers dramatically impacts care. We know that it is regional and that it can vary from urban to rural settings, from state to state, and from sections of state to sections of states. And so we need a better measure to understand what is it that we need for a workforce and where are we missing it. Next slide, please. And I think this turns it back over to Christian Bergen, who will be giving you your next part of our presentation.
Thanks, Nancy. My name is Christian Bergman. I'm a geriatrician here in Richmond, Virginia, and I am the chair of our state-based policy and advocacy subcommittee of the AMDA Public Policy Steering Committee. So I'm going to speak briefly to you all about the challenges involved with measuring supply and demand of physicians working in this space. So just briefly, maybe 20, 30 years ago, the typical physician who would come into a nursing home was likely a primary care doctor, a PCP, either family medicine or internal medicine, who had an office practice, maybe seeing folks in the hospital and was seeing nursing home patients also. because of the complexity of patients and acuity of visits and change of condition, I would say that in the last 20, 25 years, we have seen an emergence of more physicians more dedicated to this space, and primary care doctors focusing more of their attention on the outpatient basis, similar to a hospitalist inside the hospital. So for that reason, it's a little bit challenging to study. So let me just walk you through a couple of things. If we could go to the next slide, please. In regards, somebody asked who provides the typical care. This is from some billing data back in 2021, looking at claims data. Almost 50%, 47% of visits occurring in post-acute and long-term care, nursing homes, assisted living, as well as skilled nursing facilities, is by nurse practitioners and physician assistants. And a variety of other physician disciplines are involved. Internal medicine, that's IM, family practice, FP, and physical medicine and rehabilitation, PM&R. And then we also have geriatric psychiatrists, general psychiatrists, wound care physicians, and nurse practitioners, lots of other disciplines involved, but the primary attending medical team is usually internal medicine, family medicine, with a nurse practitioner or a PA. Next slide, please. In terms of trying to define the problem, I'm just going to give you an idea of a what we call demand model, in which you try to estimate the denominator, try to understand what your demand and your supply is to then calculate a shortage. So let me just use Virginia, and I understand for those following the math here, there are a lot of assumptions here, but we have about 288 nursing homes here in Virginia. Average size is somewhere around 100 residents per facility. We can assume across the board, probably close to 20-25% skilled patients. And that gives us some numbers here. When we try to figure out the expected number of visits, there are two different approaches. You can either look at the bare minimum by federal regulations, which in the Commonwealth of Virginia, a patient has to be seen within 48 hours and then within 30 days, and then every 30 days thereafter, differences after 90 days. But the rest of the visits in between are driven by medical complexity and medical need. And so that may be something like following up on a heart failure hospitalization, tracking the weight or adjusting their medications, or seeing how they respond to an antibiotic dose for a pneumonia. So it's not as clear cut. In general, in our own models, we aim to see those short stay rehab patients about twice a week and long-term care patients about twice a month. But you can see here that you can create this artificial model to help define some of the demand, and the supply side is a little more challenging. So if we go to the next slide, we think that based on demand, 467. So that, okay, so 467 full-time working clinicians and about 100 medical directors. The question now is, if I look at the Commonwealth of Virginia and the current data, how would I figure out if we have that many people working and if they're seeing those 10 patients per day, 5 days a week? We actually don't know. The billing data does not easily separate out because there's no specialty designation for this particular area for physicians, nurse practitioners, and billing codes. So you have to make certain inferences or you have to rely on surveys. So if you go to the next slide, I just want to point out that the primary care physician shortage has been well described in the literature. And what I am trying to get to you all, if you click one more, Sean, what about this post-acute long-term care? It is by internal medicine and physician, family practitioners, and it falls under primary care when they do these workforce analyses. And so it's very difficult. You see in this particular chart, they pulled out hospitalists because it's inpatient primary care, inpatient primary team management, but we haven't done the same in the outpatient setting. And so it becomes difficult to figure out in these large studies what it looks like. I might point you all to HRSA, which Health Research Service Administration on the federal level has primary care health professions shortage areas. And there are some calculations in there, percent of need met, practitioners needed in their models. I would urge you all, when you look at those papers, they define a panel size anywhere between 3,000 to 3,500 for a typical primary care clinic per doctor. That becomes a little more challenging in our environment. It's not as easy to define that panel size. So my point here is that we really need specific studies to look at this space to define our shortage. And in my opinion, here in the Commonwealth, we do not have 467 full-time clinicians. And so we're working on figuring out ways to partner with our General Assembly and trying to figure out how we can move this work forward. I will pause here. If we advance one slide, there's an opportunity for folks to think about this and chat in using the Q&A or the chat box. What questions or what have you heard in your circles around physician shortages in senior care, post-acute, long-term care, or nursing homes? I'll turn it over to
Thank you,
Dan
Nancy.
first.
Thank you, Christian. I think the point here is that we believe that the medical directors are an important part, in long-term care, and anything that can focus their importance at a state-based, as a state-based issue, we think would be really great. If anybody happens to have that solution, please not only put it in the chat, but please call me, because that would be really great if you could solve that problem for us. And I think it's something we need to keep looking at on an ongoing basis. As far as the workforce issue, I think everybody agrees in long-term care. Well, obviously, Sean, right? Workforce is the #1 problem, which you identified as part of CSG. It's something that I think rose to the top for the Moving Forward Coalition. Their goals are coming out next month. I'll be interested to see. AMDA has the Futures program, but I've been dabbling in this a little bit. And I think a lot of people would say that there isn't enough exposure to long-term care, from a very young age to, residency. So there's always, I think, an opportunity for improvement. I would say, just on a personal level, my nephew did take me to his Bring Your Uncle to School day when he was in 3rd grade. And I told everybody how great being a medical director in a nursing home was. But he's 29 now, and I don't think that made a difference with him at all. But I tried, right, Sean? So there we are. Please keep your questions coming in the chat. But for now, I think we're going to, I don't think there's any other chat. Yeah, right. So I think we're all in agreement here. So let's go to the next slide. We're now going to talk about national and state advocacy initiatives. So Alex, you are on.
Well, hi, everybody. Thanks for being on. This is obviously an exciting opportunity to talk to you all and hopefully highlight some of the issues. By virtue of introduction, my name is Alex Bardock, Senior Director of Policy and Strategic Partnerships at AMDA. I've been here since 2007. And I think since the first day I started, we've been talking about how to define the clinicians that practice in this space. And more importantly, to the discussion today, is how to ensure that we have enough clinicians that practice. So we've tried to so far define the problem for you all. Hopefully you kind of gather that it does exist. You probably knew that ahead of time, but hopefully we've fine-tuned it for you. But it's not enough to just somebody who works on advocacy to sit here and just define it. What are we actually doing about it, and how you can help in our effort to address some of the issues that we've already highlighted. Next slide. So AMDA itself, obviously we're a national medical specialty society, as has already been highlighted, by virtue of our participation with the American Medical Association and with many other specialty societies whom we partner with in order to advocate for this field of healthcare, as Nancy accurately highlighted. So we do that like anyone else does. We have a formidable agenda that we have direct lobbying in Congress and all the federal agencies, all the alphabet soup, CMS, FDA, CDC, on and on and on, that you all now are familiar with. At least 2 people now on the screen here that were at the Capitol in September should be familiar to you, myself and Dr. Vicki Walker, who'll speak in a little bit. We do a lot of grassroots advocacy with our members. Obviously, that's pretty typical in any membership organization. and we are no different. We also participate in something known as the RUC, the Relative Value Scale Update Committee. I'm not going to bore you with the particulars, but just so you understand, this is the panel that essentially looks at all the various CPT codes that are out there and decides their value. And that's obviously an important panel. Although it is known as the physician payment system, it obviously impacts the entire provider workforce, as Nancy mentioned. A lot of the codes like chronic care management cover things like social work. And in particular, now the move toward value-based medicine, where things aren't as defined by the role or the scope as it was in fee-for-service. And we also serve on many technical expert panels that come out of the Center for Medicare and Medicaid Services, very active, obviously, during COVID and a lot of the governor's task forces that Christian mentioned. And we are just pretty much trying to be at every table that is having a discussion around healthcare, because as again, I will stress that, as Nancy pointed out, this is a sector of healthcare, and without it, you do not have a healthcare system, as was evident during COVID. Next slide. So what have we done? I just want to highlight one thing. We've talked a lot about medical direction. And so we've done a lot of work around transparency. Transparency has been the word that has been used most often, probably, of what you've heard, and the Moving Forward Coalition and others around ownership transparency. Where does the money go? But while we support the transparency around ownership and are working a lot to ensure that that happens as well, what we want to highlight is the question that you all have been asking: who in the world are medical directors in a nursing home? And does the public even know that such a position even exists in a nursing home, and what is its requirements of that position? We don't know. This, I want to stress this, and we have legislation essentially that I'll talk about in a minute, but I want to stress this. This is not something AMDA wants to know. This is not because this is a membership issue. The public deserves to know this. I myself, as a consumer of healthcare, and every single person on this call is a consumer of healthcare, deserves to know who the clinical leader, as defined by the federal regulations, is of the nursing home. It is simply not acceptable that I know more about the leadership of my local grocery store, whose manager and shift managers' pictures are hung on the wall, than I do about the clinical leader of the nursing home where my loved ones are currently living. That is unacceptable and should be changed. And essentially what we're asking is that we provide transparency on what the training, the background, and the experience of those that are tasked with the enormous role of the clinical leadership and administrative roles in the nursing facility. Next slide. So what have we done about this? We last year introduced legislation that is essentially make it mandatory the disclosure of medical directors of nursing homes. Just as a reminder, every single facility, virtually every single facility, is reimbursed by Medicare and Medicaid. These are tax dollars. Out of that, obviously, this is a contracted position. But we must know who the medical director of the facility is, so that not AMDA, but the public understands that it's a retired plastic surgeon, or is it a geriatrician with years of experience? I don't know about you, but I have young children. And when I took them when they were born, when I went into the pediatrician's office, I looked at whether or not the pediatrician was licensed and had been practicing, and looked up what their experience was. I struggle to fathom how we don't do the same thing when we put our loved ones in the nursing home. The only thing that changes, quite frankly, is the person's age. And I think it is well past time that we simply provide the public this information. Just as an anecdote, I get a lot of people who call me and ask me, what should my father-in-law, my mother, are in a nursing home. Probably you might have some of the same questions. What should I ask the nursing home? What kinds of questions should I be asking? One of the first things I always tell them is find out who the medical director is. In one of these instances, the person, who is actually a former colleague of mine, said to me, hey, I called and they said the medical director was not available for several weeks. To make this long story short, the person died before the family member ever had a chance to speak with the medical director. That is unacceptable, and it should have been disclosed who the medical director was. I have no idea whether that was a geriatrician or not, or what the idea was. We hear a lot about, well, we don't do that because our medical directors are not engaged. Well, maybe they're not engaged because we're not asking anything about them and are not asking them to be engaged. If the public does ask, and CMS is asking to contact them during emergencies and COVID, then perhaps we have a more of a reason for them to be engaged, if not just the federal regulations that are currently exist. So we ask you to take a look at this legislation. It is not, it's not very long. And we do know that in various states like California already passed legislation to require medical director disclosure and certification. Massachusetts currently has a pending bill on this issue. And in North Dakota, they took a administrative route to do this as well. So this is, more and more states are doing this, and you heard Virginia is working on it as well. So hopefully this will provide this sort of transparency. Next slide. So I'll turn it over, but I'll finish with saying that the reason we're highlighting this particular issue, and there's a lot more that we're doing on the advocacy front for workforce, but the reason we're doing that is we do believe that medical direction is a start to talk about how we can develop processes, how can we have engaged medical directors or talking about vaccinations who are really become clinical leaders of the facilities, and not just sort of there by name only to comply with a regulation that's now, or law and regulation that's now 30 years old. We can make this a meaningful goal, and we can ensure that we have more medical directors that are trained and know what they're doing in the facilities. Now I'll turn it over to Dr. Vicki Walker.
Hi. Well, I'm Dr. Vicki Walker, and I am the chair of AMDA's Public Policy Committee. I also work for Avell eCare, which is a telemedicine company that provides services for people in nursing homes and assisted livings. I am coming to you from the middle of the country in South Dakota. So I think it's not a big surprise to any of you that it's been tough to get things done at a federal level for some time now. And that's historically, I think, where we've focused efforts as a national organization. But we've had a lot of conversation over the last couple of years about really to get things done. The states are where it's at. And so I'm not telling probably anybody on this call anything that they don't know. But we've become more organized about how we at AMDA are focusing on where can we have the most impact. And so internally, we've created this state-based policy and advocacy subcommittee, and Christian has done a fantastic job of getting that organized. And it was just a lifeline for many of our medical directors through the pandemic. And as we've moved through the pandemic, we've really sought out ways to just build on everything that was learned during those difficult days about how do we effectively share what's working, share things that aren't working, so that everybody doesn't have to learn the same hard lessons the same hard way. And so that's really what this committee has been doing. And we've got over 40 members from AMDA that are actively engaged in this, and more than half the states are represented in that group. So we are hosting podcasts on a regular basis. We've got resources on our AMDA website, presentations that are happening at our national conference that are coming out of this group. So it's been a really exciting evolution. And as was highlighted already, some of the early successes have really been around sharing and learning. How do we get the medical director information more front and center so that we can communicate. And so I'm pretty proud of my colleague in North Dakota for being one of the leaders on that. Another, I would say, early win has been just as this COVID strike fund teams were coming together at the state level. We've seen a lot of work of our members getting involved with those state conversations to help discern the best ways to make good use of that. If you could go to the next slide, please. So I guess what I would share with you is that as you're looking at what's happening in your state and trying to figure out what do we do next with the challenges that we're facing? I would just encourage you to reach out to your state and chapters, and you'll find each chapter has a pretty darn engaged group of physicians. If you happen to be in a state that you go looking for a state chapter of AMDA and you're like, well, I'm glad everybody has one except for us. If you're in one of those states, I think that the state-based policy group still is a great resource for you, because we've had people from states that don't have engaged AMDA affiliates, but we can still share with them what what other states have found effective. And even in states where we don't have an organized state chapter, we have members, and so we're able to to help connect those dots and make introductions, so we can help out in that way. I would just share that one of the things that Christian has done, he talked a little bit about Virginia, and he's been really active at working with with the General Assembly there to look at how it makes sense for their state to study their shortages. I am sure that there are reports and data collections and lots of different ways that you are looking at the challenges of long-term care in your state, but maybe nobody thought to put in a question about the physician shortages. And so it might be as simple as just adding a couple questions to to some work that's already happening. So I also would just share too that those reach outs I mentioned, if you're looking for for input on how to tackle some complicated issue in nursing homes, I think that you'll find that the medical directors are interested not just in telling you things, but also hearing things from you too. And if there are things that you are finding to be confusing or frustration that we're really an interested group in working collaboratively on those things. And then finally, next slide. These are some ideas as we've brainstormed around our groups about how we might move forward. We know there's a lot of work around value-based programs, around quality programs at the state level. And we just think that there's a great opportunity for some of those quality programs to perhaps focus on making some training available for medical directors or practitioners. There's some great work that's happening in GWEPS that we can connect to. There's the new provider training that we have, that was mentioned earlier in today's talk from AMDA that can be shared. But I think that making those things part of your state's approach to, to quality, I think is one opportunity. I know some states have joint meetings that happen between their state affiliate and the state regulatory bodies. So Colorado is a great example of that. So there's also partnerships that are happening with the QIOs, the quality improvement organizations that are funded to support quality of care. Great partnerships with different ombudsmen's programs in different states. So there's a lot of potential allies there. And I kind of throw a wide net, knowing we've got a lot of different kind of people on the call today. I'm sure that there are more ways that we can be working together than we've thought about. And I, would just say we would love to hear from you. And with that, I'm going to toss it back over the fence to Dan.
Thanks, Vicki. Thanks, Alex. Next slide, please. Next slide, please. Next slide, please. So look, we've thrown a lot of information at you, and I recall I asked Sean if we could have 2 hours to do this, and he said no. So to summarize real quickly here, the healthcare providers, we're not stakeholders here. We're subject matter experts, and I think that as such, it's relatively unusual to see a long-term care physician be an advocate. I think that's one of the reasons, a benefit of allying with AMDA. Next slide. So what our asks are here is we are ready and available to work with you. Just contact the state or contact national about getting in touch with involved people at your state. Try to involve people from AMDA, long-term care clinicians in these discussions. We would love you to talk to your congresspeople to support HR 177. Again, it's 200 words, it's very easy, and to be an advocate with us for training and certification. So we hope you enjoyed today's presentation. We would love if you would invite us back. I think we're out of time, right, Sean? So if anybody has questions, I think the next slide is our contact info. Do people have, no, next. Yeah, the audience has access to these slides, right?
Correct. Yes, we will.
Please contact us. We hope you enjoyed today's presentation, and thank you to all the panelists.
Dan, thank you so much. And yeah, so we'll just take a couple of minutes here and see if there are any last minute questions for these folks. But thanks to everybody for the presentation this afternoon. One thing I wanted to ask about, Nancy mentioned the AMDA Futures program, and this is something that we've heard about this kind of thing from state policymakers in a couple of states as well, that it's important to sort of hook people into this part of the profession early on to, not only build that sense of loyalty, but to show them the value and importance of these roles and hopefully get them to stick around. But what can be done really to emphasize the importance of the folks who are in these roles and to improve their quality of life so they do feel compelled to stay with it?
Right. I think that's $1 million question. And it's certainly one that, the futures is one part of what we're trying to address. But it's really an understanding that people are really choosing their fields of interest and moving in those directions earlier and earlier. And so we think it's really important to get early access to nursing homes, to, whether it's high school students and having career experiences, having shadowing days, just visiting individuals and getting them out there. Dan is working with Penn State University, but we're hoping to, maybe that's something that can be scalable to larger universities for their pre-med programs. The futures programs, really trying to kind of open up. You tend to go into what you've been exposed to, and you don't gravitate towards something that you don't even know exists. I'm a very big advocate that unfortunately our nursing homes became kind of black boxes and were closed through most of the pandemic. And while we are seeing, visitation resume, et cetera, I don't think to the degree that it was before. And so we are going to have several years of individuals who maybe have never stepped foot in a nursing home before making, career decisions, whether they be for nursing, for, therapy, for anything that would involve working in a nursing home. I don't know if any of our other panelists have anything else to add to that discussion.
I think that's spot on.
Great. The one other question that I had was, sort of to tie things together here for folks who are have been with us for the last couple of meetings. Last month, we had folks on from Alzheimer's Association and from the Milken Institute talking about the dementia care workforce specifically. What is your all's feeling about, developing those folks? Because obviously, lots of folks in nursing homes who have dementia. As I mentioned before, both of my 83-year-old parents are among them. But what is needed as far as training of those folks, and how does that factor into the folks who are your members?
Vicki looks answerish. Did you, Vicki? Am I right?
Sure. I think it's critical. I think that. I think that you'll find that AMDA does a lot of promotion for good dementia care, and we think it's absolutely critical that the staff receives good training also. So I don't think it can be overemphasized. I think it's incredibly important.
But it's tricky though.
Can I chime in?
Go ahead, Christian, and then I'll have something to say.
Yeah,
Go ahead,
just real
Tristan.
quick, I think it was mentioned before the GWEPS and HRSA, in terms of geriatric workforce enhancement programs. There are a number of GWEPS across the country, and I know that there have been supplements released by HRSA in the last 3 years that focus on CNA education around dementia, as well as connecting RN students and CNA students to this particular initiative. So we're doing one here in Virginia, focusing on text-based, or where folks CNA sign up for a class and they get texts and they watch these little videos. We're trying ways that we can disseminate education in little tidbits to folks outside of the traditional classroom, or getting people together. We need scaling of these resources. The training material is available. It's how to implement it and how to scale it up to a large workforce. Intermittent success on it, I think there's a lot of smart people looking into this, but the resources are there. It's implementation and making it exciting and for people to learn about. So sorry, Dan, I'll turn it back to you.
Oh, that's okay, thanks. I think this is one of the benefits of allying with an organization like AMDA. Training for groups may or may not be in our purview, but I think we can help with causes that are correct. Like I've heard that Delaware has a bill that has talked about mandatory training, like 12 hours of training for dementia. It's going down in flames, right? And it's hard I don't quite understand it. I don't know the details, I'm from Pennsylvania, but I think this is where, physicians allying with people who are politically savvy to try to work on common causes. I always feel that when you do advocacy, it's good to go from a position of right. You're doing a morally correct thing. So if you can understand why, to me, that seems to be a no-brainer. Why wouldn't you want to train people on dementia care? But it's not. It's going down. So I think it's really a good case study, perhaps, to learn from and figure out why. Now, the other thing, just briefly, is it's similar to care and assisted living, where there's a lot of assisted livings for memory impaired residents, and which presents its own unique challenges. Again, it's a separate thing for advocacy, which is how can you have best practices in regulations or policies and procedures that leads to training. So, other people may see problems, I see opportunities, but I think a lot of opportunities come from, education and collaboration.
Yeah, Dan, the only thing I'll add, I think it's a very important question because one of the ramifications that we know that happens because of workforce shortages is the use of unnecessary medications, which is the other focus of moving forward, and many others, in particular antipsychotics, and the focus of Congress on the use of antipsychotics, and how that very much connects to the training of the workforce and the number of workforce that's available. We spend a lot of time, I think, as Nancy mentioned at AMDA, talking about what are the proper behavioral interventions, what you should be doing, what you should be looking for, and when it is appropriate or inappropriate to use certain medications. It becomes much more difficult when you have staff turnover at a high rate, or you don't have staff to do those things that are ideal to do. AMDA actually has a program or initiative, I should say, called Drive to Deprescribe, knowing that an average patient in a nursing home, I think, is clinicians can correct me, please, but more than 12 medications, and that's something that has to be managed. And a lot of them, maybe you can get rid of some. We are seeing that certainly through that initiative, that many facilities working with clinicians can do that. But again, I think it takes that sort of training, and I think it takes understanding of what the workflow, which I'm not quite sure that there's a great understanding with, hopefully we've highlighted, on what that workflow in a nursing facility or even assisted living actually looks like.
And the use, obviously, of non-drug treatment versus drug treatment, which ties very much so with staffing and retention. But
yeah, and the families sort of demand, or the families can be asking a lot of good questions, right? Or their understanding of these complex issues and complex medical conditions, quality of life issues, advanced care planning goals, all kinds of things, all comes into play. And this is why we've been talking so much about training, because if you just put a body into a building that has never done advanced care planning with a person at end of life, or has never looked at, that many medications and counter, what's going on drug and drug interactions, what you can get rid of, what you can't, what are the goals of care rather than, going home, because this isn't necessarily that type of situation. This is what we're talking about when we're talking about geriatricizing healthcare a little bit, because it's always, I will say this, it's always amazing to me that we have to prove, now listen to this carefully, that we have to prove that geriatrics are important to Medicare. Medicare, which covers people that are older than 65, we are trying to sit here and prove that geriatrics are important. That's always been an amazing kind of little factoid to me.
Well, everybody, I appreciate everybody sticking around for just a little bit longer past our end time, but we are at the end of our time together. I want to once again thank the folks at AMDA for joining us. A couple of quick notes before we leave you. For our next meeting of the network, which we expect to be in late July, we hope to focus on state efforts to develop career pathways for long-term care workers. We're also planning to drill down on the shortage in home care workers for HCBS programs at a future meeting. We will send around a Zoom registration link soon for our next meeting, and we hope you will be able to join us. We welcome your suggestions for future meetings as well. We are working to develop our National Online Resource Center, which will be at that URL on your screen once it is up and running, in case you want to go ahead and bookmark it. Please send us your relevant bills, reports, resources, articles, and initiatives for us to include on the website about what is going on in your states regarding the long-term care workforce. If you would like to request on-site technical assistance services, please don't hesitate to reach out. Thanks so much again for joining us today and participating in the discussion. We will talk again soon. So long.